Welcome, everyone, to this symposium. We will start in just a few seconds, giving some time to people to connect and all of their audio devices to fully enable.
Okay. So welcome. Thank you for coming to our symposium on polypharmacy, problems and solutions for its methodologic challenges in real-world data. Our faculty today are a diverse group of folks that I think you will enjoy presentations from. I'm Amy Justice. I'm the C&H Long Professor of Medicine and Public Health at Yale University and a staff physician at VA Connecticut Healthcare System. Dr. Christopher Wrench is Assistant Professor in Epidemiology at the London School of Hygiene and Tropical Medicine and at Yale School of Medicine. Dr. Kersha Gordon is Assistant Research Scientist, Biostatistician, and Epidemiologist at the Yale School of Medicine. Jonathan Romero is a doctoral candidate in Energy Science and Engineering at the University of Tennessee and Oak Ridge National Laboratory. Jordan Guillot is a pharmacist and was a recent Fulbright Scholar here at Yale University and is now at the University of Bordeaux. And Vincent Loret is the Associate Professor of Medicine and Epidemiology at the Perelman School of Medicine at the University of Pennsylvania. Our outline is that I will start with a brief introduction to the issues around polypharmacy. This will be followed by Chris Wrench presenting on measurement of polypharmacy and confounding by indication. Kersha Gordon and Jonathan Romero will do a combined presentation talking about statistical and machine learning approaches to this problem. Jordan Guillot will talk about identifying potentially inappropriate medications or PIMS in the context of polypharmacy. And Vin Loret will talk about approaches to estimating cumulative toxicities. This will be followed by a discussion that we hope everyone will participate in. I have no conflict and my funding is listed here. So polypharmacy. Polypharmacy is the use of multiple medications simultaneously. A typical threshold for polypharmacy is 5 or more medications, often prescribed to address multiple medical problems. The prevalence of polypharmacy is increasing worldwide with advancing population age and improved access to medical care. Yet it has not been extensively studied. Medications are typically approved without extensive consideration of their effects in the context of other medications. Some have assumed that the strong dose-response association observed between medication count and adverse health outcomes is solely due to reverse causality. That is, sicker patients, those who are older or more frail due to multimorbidity, are on more medications, rather than that more medications make patients sicker. Both are likely true. Specifically, sicker patients are on more medications, and too many medications can make you sick. Thus, it is impossible to draw a single directed acyclic graph or DAG. Instead, polypharmacy is a wicked problem with complex interacting causal relationships difficult to capture using conventional statistical approaches. One might ask, why not simply intervene if we know that the number of medications is a problem? Interventions to date have not been very successful. They have focused mostly on potentially inappropriate medication reduction, but at the same time, other medications are often added based on guidelines. It's not clear what the goal of the intervention should be, whether it should be decreasing the amount of absolute number of medications or decreasing PIMS. We need a better understanding of mechanisms of harms if we're going to appropriately target our interventions. At its core, polypharmacy is a numbers problem. The more medications an individual is on, the more adverse effects are observed. And frail patients, those who are older, sicker, with multimorbidity, may be particularly susceptible to harm. In addition to frailty, risks from harm from polypharmacy may also depend upon interacting factors, including alcohol and other substance use, which can both directly contribute to physiologic injury and interact with harms from polypharmacy. Similarly, pharmacogenomics may also contribute to the degree of susceptibility to harm from polypharmacy. But our conceptualization is centered on measuring the cumulative injury from polypharmacy and beginning to understand how much of the cumulative injury is contributed by particular mechanisms. All of the presentations today will employ, at least in part, data from the Veterans Healthcare Administration electronic medical record, which is a unique resource for this problem. It is a national sample of more than 20 years of longitudinal records, including more than 20 million patients. It encompasses both inpatient and outpatient diagnostic codes and notes, pharmacy fill-refill data, laboratory, pathology, microbiology, and radiology reports, and complete death data due to the death benefit that the VA pays. We also have the ability to merge data from Medicare, Medicaid, community care, fee-for-service, and National Death Index cause of death data. We also hope to study this question of polypharmacy and other large samples, some of which you may be able to tell us about. So to wrap up, polypharmacy is a wicked problem well suited to the use of real-world data. There is no one right way to study this problem. Rather, triangulation is needed to ensure consistency of findings, and mechanistic studies are desperately needed if we are to separate correlation from causation. We'd also like to say a thank you to the VAX Polypharmacy Work Group that has really helped develop our thinking along these problems. Its membership is listed here, and we are certainly open to others joining if there is interest. With that, let's go to the first presentation by Christopher Wrench.
Thank you, Amy, and thank you everyone for joining our symposium today. My name is Christopher Wrench, and I would like to thank the ICP organizers for allowing this opportunity to discuss and determine best practices to studying this real world and ever increasing problem of polypharmacy. I have no conflicts to report, and this work was supported by the NIAAA. In my talk, I'll ask whether it is possible to estimate unbiased estimates of the effect of polypharmacy in real-world data. And in particular, I will highlight key challenges and raise some potential solutions for discussion surrounding the measurement of polypharmacy and concerns of confounding by indication. As we all probably know, medication data are messy. Take this prescription diary for an individual patient, for example. We spend a lot of time interrogating prescription data to identify exposure to just one or two drugs of interest. For polypharmacy, we're interested in all medication exposures. Therefore, we need to develop best practices for an accurate measure of polypharmacy at the individual level. And in the VA data that Amy described, we have over 20 years of inpatient and outpatient prescription fills and refills provided to over 20 million patients. Therefore, we also need to ensure algorithms that measure polypharmacy are efficient and can scale up to process billions of medication records. So what has our group learned so far? Not surprisingly, the choice of algorithm to measure polypharmacy depends on the research question, and examples of various use cases will be detailed by my colleagues later in this symposium. The most common definition we use is one that we call chronic polypharmacy. For this, we start with a data set that includes one prescription per row. The algorithm then rolls up all refills for a prescription into a single record, capturing the start and stop dates of the entire treatment period. During this roll-up, we typically allow grace periods of up to 50% between fills to allow for stockpiling of medications. And with this new data set, we then count the number of chronic medications a patient is on at any given time point. So far, we have defined chronic medications as those with at least 6 months of continuous use for the purposes of our studies, but of course, this is likely to change based on the specific research question. Now, let's turn to confounding by indication, which is demonstrated by this simple confounding diagram. To arrive at a true causal estimate of any drug exposure in pharmacoepidemiology, one needs to adjust for all indications for the drug that are also common causes of the outcome under investigation. For example, in a study investigating the effect of the opioid oxycodone on the risk of heart attacks, we should account for all indications for initiating oxycodone, such as pain. However, things get tricky when it comes to capturing all indications of polypharmacy. Why? Well, because each patient is on a different combination of medications. In short, one person's polypharmacy is not the same as another person's polypharmacy. So let's quickly turn back to the mechanisms through which we hypothesize polypharmacy causes harm. Essentially, the problem we have is disentangling the effect of polypharmacy from the effect of physiologic frailty, so that we can isolate the effect of polypharmacy. We propose a potential solution by adjusting for validated metrics of health status and frailty. The Charlson Comorbidity Index is based on diagnostic codes of 17 different clinical domains, shown here in the box on the left. It measures multimorbidity and has been used as a mainstay adjustment for overall disease burden by thousands of investigators for decades. The Veterans Aging Cohort Study, or VAX Index, is a validated composite measure of physiologic frailty comprised of routinely available clinical laboratory data, including hemoglobin, FIB4, eGFR, albumin, white blood cell count, among others, shown in the box on the right. Both measures are strongly associated with polypharmacy, morbidity, and mortality, as demonstrated in this graph. But what is the relationship between health status and polypharmacy? Is it multimorbidity or frailty? And the short answer is, we don't know. But what we do know is that some patients may not have many diagnoses, but be really frail, and vice versa. So what we have done in our analyses thus far is adjust for each measure individually and together, and show and interpret any changes in estimates of the effect of polypharmacy. In this example, we see that the unadjusted hazard ratio for polypharmacy is 5. We also see that adjusting for VAX index had a more dramatic impact on the estimated hazard ratio than Charlson alone. And we can use this information to develop further hypotheses to test in the data. Let's once again briefly return to our mechanistic model. We know that polypharmacy is highly correlated with potentially inappropriate medications, or PIMS, drug-drug interactions, and renal and hepatic toxicities, just to name a few. Therefore, we may ask, is the key driver polypharmacy, or is it some characteristic of the combination of medications? While our main goal is to understand harms from polypharmacy, we have in the interim also developed methods to investigate broad classes of medications. So we turned to the literature and found evidence that certain classes of drugs, including anticonvulsants, antipsychotics, and opioids, increased the risk of infections like pneumonia through several identified mechanisms, including sedation and modified alveolar macrophage function. We also know that alcohol consumption independently increases risk of pneumonia through similar mechanisms, and thus may have a synergistic effect. What we noticed about the drug classes in the suspect drug classes had in common were their neurocognitive effects. Thus, instead of choosing a single drug class on one end of the spectrum, or total medication count on the other end, we chose a middle ground by investigating all neurocognitively acting, potentially inappropriate medications, or NCPIMs for short. So in terms of confounding by indication, we hypothesized that our outcome of interest, pneumonia, was not an indication of the exposure to neurocognitive PIMs. Therefore, we reasoned that the pathway between indications for the exposure and pneumonia was blocked. Now, neurocognitive PIMs account for 116 different medications, each with their own set of indications. So even if we wanted to test this hypothesis, or indeed adjust for all indications, this would likely remain an issue. Therefore, we adjusted for both the Charlson and VAX index. Here's a table of some example results from one of our studies assessing the effect of neurocognitive PIMS on the risk of pneumonia by level of alcohol consumption. We were able to demonstrate that neurocognitive PIMS on their own increase risk of pneumonia with a hazard ratio of 2.4 in an unadjusted model. Through sequential sets of adjustments, we see that hazard ratios remained largely consistent in all models. And if we look down the rows, we were able to demonstrate elevated risk amongst those who reported moderate or heavy alcohol consumption during the time of their exposure to neurocognitive PIMS. Earlier this year, we presented these issues at an international workshop in a so-called methodological Dragon's Den, the original and dare I say much better version of the American Shark Tank. The of Dragons consisted of several expert methodologists and causal epidemiologists, including Miguel Hernan and Jonathan Stern, whilst our goal remains to investigate harms from polypharmacy. The panel agreed, after much debate, on our middle ground approach of selecting classes of drugs with similar mechanisms of action, like neurocognitive PIMS. But questions remain. What we are curious to know from the entire audience here today: are you satisfied with the use of the Charlson and VAX index to adjust for general health status rather than each indication in models studying polypharmacy or even neurocognitive PIMS? If we stick to a strict approach of adjusting for all indications, is this even possible in electronic health record data? For example, even a single class of drugs like opioids has a very large list of indications, all of which not necessarily captured in routinely collected data. Which leads to our final intentionally provocative question: since there is no appropriate target trial to randomize individuals to polypharmacy, if we insist on adjusting for all indications, then can we simply not study its potential harms? Please do let us know what you think in the chat at any point in this session, and we look forward to the discussion. I also want to acknowledge the VAX polypharmacy work group that Amy covered, who have been working for years on approaches to study polypharmacy, including what you will hear in the next few presentations. If you have any further thoughts or questions, please reach out by email or Twitter. Thank you.
Thank you, Chris. Now, Kirsha Gordon and Jonathan Romero will discuss combining epidemiological, statistical, and machine learning approaches to polypharmacy. Kirsha?
Thank you. Hello, everyone. My name is Kirsha Gordon, and I will talk in the first 5 minutes about VAX polypharmacy work we've done with traditional method, and then Jonathan Romero will talk about machine learning approach and known pairwise drug-drug interaction. I will then follow with our latest work. We have no disclosures to declare. As indicated by the prior presenters, polypharmacy is a numbers problem, and our work so far has looked at medications and medication count. In this presentation, we are considering to what extent pairwise drug interaction explains the association between medication count and outcomes, example, hospitalization. In this section, we'll go over the traditional method used to look at polypharmacy with 3 things in mind. Polypharmacy is associated with adverse health outcomes, such as hospitalization and mortality, that cannot be addressed by randomized clinical trials. And people aging with HIV may be at greater risk than their uninfected counterparts, as they're on life-sustaining medication of 3 or more antiretrovirals and will cross a threshold for polypharmacy as they age. Also, does pairwise drug interactions, KPDI, explain the risk of these adverse health outcomes? Example, hospitalization. Several observational studies have looked at polypharmacy and found it's associated with poor adherence, adverse drug events, falls, high-risk medications and inappropriate prescribing, and hospitalization. In our initial study, we conducted a prospective analysis on 49,285 patients in care with and without HIV. Patient medication profile were ascertained from the pharmacy database during the baseline period, October 1, 2008 to September 30th, 2009. And follow-up was from October 2009 through September 2015. Our exposure was non-antiretroviral medication count, meaning ARVs were not included. Our outcomes were hospitalization on all-cause mortality. We used Cox proportional hazard models to determine the association between non-ARV medication count and hospitalization and mortality, adjusting for demographic factors and severity of illness as a way to partially address confounding by indication. That is, sicker patients taking more meds. Our study population included people with HIV virally suppressed and receiving ARV therapy and uninfected counterpart who were receiving at least one prescription medication from the VA. I'm going to quote the overall because results were similar by HIV status. Overall, the sample was predominantly 50 to 64 years of age, 65%, predominantly male, 97%, and racially and ethnically diverse, 47% were Black and 9% were Hispanic. This figure shows non-ARV medication count by HIV status. People with HIV are the red bars and uninfected the blue. Note it appears as non-ARV medication count increases, HIV are on equal or less medications than their uninfected counterpart. However, these were patients with suppressed viral load and on therapy, and it's likely they are on more with ARVs, traditionally 3 meds. So using the traditional Cox unadjusted and adjusted models, controlling for demographics and severity of illness to partially account for confounding by indication, we found as medication increased, so does the risk of both hospitalization and all-cause mortality. And there was a difference by HIV status for mortality in both unadjusted and adjusted Cox models. As demonstrated in this figure, the top 2 graphs shows results for hospitalization. The bottom 2 show mortality. On the left are the unadjusted models, and on the right are the adjusted models. And the dark circles are HIV positive, and the open circles are uninfected. For mortality at the extreme end, counts were fewer, as evident by the wide confidence intervals. So we are not sure the deviation is true and why HIV appears to be doing better. But in both HIV positive and uninfected, there was a clear dose response associated with hospitalization and mortality, and neither demographic factors nor severity of illness explain these associations. That is, it was not sicker patient taking more meds. However, could the association be explained by drug-drug interaction? Now, Jonathan Romero will talk next about machine learning and polypharmacy.
Thank you, Kirsha. So if these associations she mentioned can be explained by drug-drug interactions, how do we actually detect which of those have a significant effect? They're a complex problem because of the extreme common networks involved. If any drug could interact with any other drug a patient is taking, the amount of potential interactions to measure will scale exponentially to the number of drugs a patient is taking. So this becomes a very intractable problem. However, one of the ways that this can be approached is with a machine learning or artificial intelligence AI approach. Models traditionally are just trained on a data set and used to provide a prediction. And these have been shown to be extremely accurate. However, they're often a black box. Basically, they're not useful for understanding the problem at hand and just used for prediction. We don't know why specific decisions are made most of the time, and we just have the prediction as it is, regardless of how accurate it is. However, we can use some extremely useful techniques from machine learning and artificial intelligence and apply it to a traditional model. One such example of this is when calculating a Cox regression model for hazard ratios, we can apply a technique called bagging. Basically what bagging is you take your original data and all of your samples, you break it up into multiple subsamples sets. A subsample set is going to have the same number of overall samples that your original data has. However, when you're sampling from that, you sample with replacement. What this means is some of your samples will be duplicated, and each of your different subsets are going to be diverse from each other and unique. What this does is when you train a model on each of these new subsample sets, is you produce a model that has specialized and learned very well this subsample that is based on the true model, the true data set, but slightly different and learning slightly different characteristics of the overall data set. When you aggregate and combine these together, what happens is that spurious relationships that may exist in your original data are dampened, while true relationships are powered up. And this is because of the nature of the resampling. When we bag these together, we get an averaged classifier, as I have in this image, that is stronger than just an individual model trained on just the original data. So I want to talk about the data a little bit more that Kirsha had introduced. Effectively, this is the survival rate of the population in the follow-up time period. And you'll notice that the green line is the overall survival rate of the population, where the HIV positive line is represented in red, and the HIV negative population is indicated in blue. You'll notice that these populations have fairly similar survival rates over this time period, and that's most likely because of the ARVs that the HIV positive population was taking, hopefully appropriately suppressing the virus within those patients. Next slide. In order to address the intractable problem that I mentioned earlier of just the sheer number of possible drugs, we decided to focus on known pairwise drug interactions, or KPDI. And for this, we looked to Drug Bank's list of drug-drug interactions. They list over 300,000 pairs of drugs that have some interaction with each other, whether positive or negative. From this, we looked to the drug data set that we used for this patient population, which included over 500 drugs, not including things like vitamins, vaccines, dietary supplements. So for the pipeline for this, we're going to take we took each of these known pairwise drug interactions from Drug Bank. We wanted to calculate a hazard ratio of mortality using the Cox regression model for each, given the follow-up time frame. We used VAX index as a covariate in the model. This is in order to account for patient health. And I used the bagging technique that I mentioned earlier, over 1,000 permutations of random subsets of the population. With this, we take each reported KPDI by those subsets for each of those pairwise drug interactions, and average the results that had a less than a 0.05 p-value. Again, this is to account for spurious relationships, removing things that didn't have an appropriate p-value. And then from this final KPDI for each, from this hazard ratio that we've calculated from each KPDI, we can calculate a KPDI index value for each patient by combining their KPDI's effects from each of the drug pairs that they may be on. So to go back to the image I showed earlier, in this method, the original data is all of our patients in the population. When we're bootstrapping, we're taking the random subsets of patients. So individual subsets may have a patient's record duplicated, but this is a part of the model. We then, the aggregating steps, when we're training the model, we're calculating a hazard ratio beta value from the Cox regression model. And then the actual bagging step is averaging the beta value for each of those KPIs to produce a population-based KPDI based on this technique. So if we look at the results, this is the survival rate of the overall population. So in yellow, we can see that's the same survival curve that I showed earlier. In red, we have neutral KPDI. In purple, we have protective KPDI, which is a hazard ratio less than or equal to 0.66. And in green, we have a harmful KPDI. So these are patients that have an overall KPDI index from the drugs that they have taken, their prescribed overlaps of greater than 1.5. We notice here that obviously that the negative KPDI has the patients in that population group have the lowest survival rate, whereas the patients in protective are better off than the overall population. However, we notice that the neutral KPDIs, so the ones between those two hazard ratios, have the highest survival rate. This could be because of something that Kirsha mentioned earlier with the lowered drug load, so less polypharmacy effect. Patients who have fewer drugs are more likely to have a more neutral KPDI. However, this looks different when you start breaking out the population by HIV status. In this graph, the red lines represent the HIV positive patients, while the blue lines represent the HIV negative patients. The solid lines represent patients with the neutral KPDI that I mentioned. The dashed lines represent patients with protective KPDI range. The dotted lines represent patients in the negative or harmful KPDI range. From the first slide I showed on this data, remember the overall population survival difference between HIV positive and HIV negative was relatively small. Here, we can see that when accounting for KPDI range, the survival rate of HIV positive and negative patients diverges significantly. Each line for HIV negative patients is significantly higher than the respective HIV positive line, despite the overall population's similar survival rates. While the difference between protective and neutral lines from negative to positive are significant, the greatest disparity is between negative or harmful KPDI lines. The survival line for harmful KPDI or HIV negative for HIV negative patients is roughly the same as the neutral KPDI HIV positive line, while the HIV positive line is the lowest by far. This all suggests that KPDI, when accounting for overall patient health with VAX index, has a larger effect on HIV positive patients. So overall, the results of this work is we have hazard ratio and beta values from Cox regression models for 5,800 known pairwise drug interactions. This is based on the drug bank version 5.0 dataset. We've also produced a weighted known pairwise drug interaction value for each patient by summing the beta values using weighted by duration of the prescription overlap. Now back to Kirsha to talk about more how to incorporate this into the larger picture.
Thank you, Jonathan. So building on our prior work and incorporating drug interaction from machine learning, we then explore the association between known pairwise drug-drug interaction, KPDI, and medication count, the degree to which KPDI drive association between medication count and hospitalization, and whether these associations differ by HIV status. Also, how much excess risk associated with medication count remains after accounting for severity of illness and KPDI. This work is now in press at Lancet Healthy Longevity. We use nested Cox models stratified by HIV status to estimate the association between medication count or measure of polypharmacy and time to hospitalization, incrementally adjusting for demographics, severity of illness, and KPDI index. First, we looked at bivariate analyses and observed a greater than expected association between medication count and KPDI in people with and without HIV. In this figure, we see by the orange line that when medication was randomly selected, the association of medication count with KPDI count was linear. For each additional medication, random selection predicted an additional 0.51 KPDI. When the actual medications were considered by HIV status, the slope of the association was steeper but remained linear. This means with each additional drug, people had a lot more interaction than if we randomly select them, because these drugs are picked based on guidelines to treat conditions. And therefore, there are more interactions than you would expect because medications given to address specific health conditions have overlapping mechanisms and toxicity. For each additional medication, both people aging with HIV and uninfected experience almost 3 additional KPDI. People aging with HIV, the yellow line, having the steepest slope. So among people with HIV, we see in the unadjusted model with each additional medication, there was an 8% increased risk of hospitalization. This association was attenuated as illustrated in these nested Cox models as we account for severity of illness and KPDI, going from 8% down to 6%. But severity of illness and KPDI did not completely explain away the association we found in our earlier work. So accounting for demographics and severity of illness, both people with HIV and uninfected individuals experience increased risk of hospitalization when exposed to increasing non-ARV medication. This risk is partially explained by KPDI, and the number of KPDI increased dramatically with increasing medication counts well beyond what would be expected by chance, especially for people with HIV. In future works, we will apply the same approach to a general population next, look at validating our work outside VA data, Look at potentially inappropriate medications or PIMS. Look at other interactions such as alcohol and/or substance use. Look at drug-gene interaction and consider alternative ways of weighting severity.
From the machine learning side, we can also incorporate algorithms called explainable artificial intelligence, XAI. These methods are traditionally considered no longer a black box. Basically, we can understand and mine the algorithms themselves for what they're learning from the training data. Methods can be trained on the same data and isolate specific polypharmacy effects that we may be looking for. And we can incorporate KPI effects in these models to be counted as a covariate. Methods like iterative random forest can determine effect from overall drug load and unknown drug interactions.
This work was funded by the National Institute of Health and the National Institute of Alcohol Abuse and Alcoholism. Thank you.
Thank you, Kirsha and Jonathan. Now we will go to Jordan Guillot's presentation on identifying potentially appropriate medications in the context of polypharmacy. Jordan?
Thank you, Amy, and thank you everyone for joining this symposium. I'm Jordan Guillot, pharmacist and pharmacoepidemiologist. My presentation today is about how to identify potentially inappropriate medications, PIMS, in the context of polypharmacy, using two different databases in France and in the United States. So I have no conflict of interest, and this work was funded by grants from the French Medicine Agency, the NIH, the Fulbright Program, and John Walters Edition. You will find these studies in two papers. One is published at the Journal of Clinical Medicine, and another is about to be submitted. So let's get back to this figure. We are exploring several harmful mechanisms of polypharmacy, such as interactions presented by Kirsha and Jonathan, or harmful biological mechanisms mentioned by Christopher earlier. In this presentation, we will focus on potentially inappropriate medication, PIMS, assuming they play a role in the increased risk of mortality and morbidity associated with polypharmacy. Potentially inappropriate medication are defined as medication whose risks outweigh benefits. It may be because of their mechanism of action, because it's harmful. This may be especially true in older patients in whom pharmacodynamics and pharmacokinetics change because of age or multiple diseases. The medication can also be harmful in younger patients, especially for chronic use of drugs that are indicated for short-term treatments. Harmful mechanism of potentially inappropriate medications can also come from drug-drug interactions, drug-disease interactions, or interactions with life habits. To identify those medications, we can use PIMS lists. PIMS lists are made by experts, often after Delphi techniques. These lists aim to identify drugs that are inappropriate either most of the time or according to certain features like comorbidity. Most of the time, they were created to be used in people aged 65 or 75 and over. Some lists were developed specifically for younger people, such as the PROM criteria. But the PROM criteria often overlap with classic lists that concern people aged 65 and over. Most often, the reason is that the chronic use of supposed short-term treatments is harmful at old age. A literature review references 36 PIMS lists. You can see some examples, the Beers, the Laroche list, PROMPT, Stop and Start. These lists were created to help clinicians in their practices. More recently, researchers have used them to identify PIMS in electronic health records. As explained by Amy and Christopher, polypharmacy needs to be addressed by real-world data. Because of the various features of polypharmacy, we can't address it by clinical trials. Therefore, electronic health records are ideal data to address polypharmacy. Most of the time, it is studied only in patients aged 65 and over. However, the prevalence of polypharmacy is already high in younger patients. So polypharmacy should be addressed at all age. Different patients with different various polypharmacy patterns exist. So we need individual medication data, which ideally include duration of treatments and dates. In these studies, we will focus on chronic medication. And we will talk about two different electronic health record databases in this presentation. The VA database that was presented by Amy and Christopher earlier, and the French database, the SNDS, for Système National des Données de Santé. In France, there is a unique healthcare insurance system which covers the whole population. So all claims are collected in one database for the whole French population, so about 66 million people. Claims include pharmacy data, inpatient, outpatient data. We can also find some demographics and location data. So the objective is to present a method to estimate the prevalence of chronic polypharmacy and PIMS in the French and the US veteran population. Let's talk about the medication data we can find in these two databases. In both, we have the names and substances of the medication and a specific code. The anatomical, therapeutic, and chemical ATC code in the French database. This is an international classification by the World Health Organization. The US database has its own code called RxNorm that concerns therapeutic classes. Both databases include the date of fill and refill, the dose, and the number of units per refill. The US data includes durations of treatment. The French database does not, so we will need to estimate them. The French database does not include medications used during inpatient stays, so we estimate them from the medications people had at admission. So I will now present the method used to estimate periods of treatment. In both databases, we use the dates of fill and refills to estimate the start of a treatment. As I said, durations of treatment are available in the US data. They are not in the French data, so we estimate them either from external information, like mean durations in clinical practice found in other surveys, or from the number of units and the dose of the medications delivered. After defining these periods of treatment, we added a grace period to take account of small disruption of treatment that could be due to patient storage. As Christopher explained, it's usually up to 50%, but in the example today, we will take 20%. So here is a random patient as an example. We see on this figure all fills and refills of 7 different drugs, A to G. We estimate durations of treatment of each medication that you can see in green. And we add grace periods, in this example, 20% of the last refill that you can see in orange. We have then estimated all periods of treatment over a year for this patient. We need now to define chronic medication. In this example, we consider a chronic medication as a medication with at least 6 months of continuous periods of treatment. Then we define polypharmacy as the use of at least 5 chronic medications on a given time. So back to our example, we identify first all medications with at least 6 months of period of treatment. So those are the chronic medications. Then each month, we count the number of chronic medications. When there are 5 chronic medications or more, our patient is with polypharmacy. So 2 periods here. Let's now identify the PIMS among these chronic medications. We are going to use PIMS lists. In this example, we are going to use the Beers criteria. The Beers criteria lists medications that may be potentially inappropriate most of the time in people aged 65 and over. Since most of these medications overlap with the PROM criteria that concern people aged between 45 and 65, we applied Beers criteria at all age in our study. We are also assuming that most of Beers medication could be inappropriate in anyone if their use is chronic. Beers criteria also lists medications that are inappropriate with certain clinical conditions. And to identify those conditions, we need clinical or biological data. And the US database is rich in clinical data. all diagnosis information about healthcare performed at a VA facility are in the database. We have outpatient and inpatient diagnosis and lab results. In the French data, we have inpatient diagnosis, but we do not have outpatient diagnosis or nor lab results. So let's get back to our example again. Let's look at the medications that are chronic, and let's take two examples, a short-acting benzodiazepines and a selective serotonin reuptake inhibitor, SSRI. So the first one is an anxiolytic, and the second one is an antidepressant. This patient had an outpatient visit in January and an inpatient visit in June. So if we use the French data, we see that the inpatient visit was because of a fall. We don't have diagnosis for the outpatient visit. So according to Beers, short-acting benzodiazepine should not be used more than 3 months, so they're inappropriate, and SSRI should not be used with history of fall. From the US data, we know that the outpatient visit was about chronic anxiety. And according to Beers, short-term benzodiazepine should not be chronic, except if the patient has chronic anxiety. So we found that those medications are not pills. From this information, we can now define periods with polypharmacy and potentially inappropriate medications. From the French data, we have all polypharmacy periods include at least one pill. And from the US data, thanks to the richer clinical data, we know that only one period include at least one pill actually. So the results of the application of this indicator in both databases in 2016 are shown in this table. On one hand, we use the representative sample of 276,000 French people aged between 45 and 112 years. On the other hand, we use the sample of 2,750,000 veterans aged 49 to 70 years. Mean age was similar between both samples. And we observed a higher prevalence of polypharmacy in the USA, 30%, than in France, 13%. We also observed a higher prevalence of PIMS with at least one PIMS in the US, 20%, than in France, 8%. But in both cases, the most frequent PIMS were proton pump inhibitors. And the second most frequent PIMS were short-acting benzodiazepine in France and sulfonylureas, an anti-diabetic, in the US. So both databases are big and allow to study polypharmacy in whole populations. The French database provides information about the national French population. The US database provides information about US veterans, not the national US population. However, it is one of the richest electronic health record database in terms of clinical and medication data. And most importantly, using those two different databases and comparing the results, we were allowed to better understand the PIMS situation in polypharmacy in the real world. Prevalence of PIMS and polypharmacy was higher in US veterans than in the French population. This difference may be due to differences in age, comorbidity, or healthcare practices. And thanks to both databases, we can say that polypharmacy in 2016 was frequent and frequently included at least one PIMS. We can assume this is true and should be addressed in both the French and US national populations. We observed similar most frequent PIMS in France and in the US. In both populations, the most frequent one was the PPI, proton pump inhibitor, a drug that reduces stomach acid production. PPIs are not supposed to be used chronically. So chronic use of PPIs is probably a concern in both the US and in France. We can assume that similar frequent PIMS, such as the PPIs, are features of polypharmacy. regardless of the population, health status, or age. And they should be addressed in priority to have a chance to prevent some mortality and morbidity burden associated with polypharmacy. Some frequent PIMs were also different between the two populations. They might highlight differences in healthcare systems. For example, the sulfonylureas, that's an anti-diabetic that can cause hypoglycemia. And while anti-diabetic treatments are completely covered in France, they might be expensive in the US, especially insulins. So that leads patients to use cheaper treatments or maybe to have less balanced diabetes. These PIMs, the different ones but still frequent, should be addressed too, but we should also take account of healthcare differences between countries. Merci, thank you for your attention. I want to thank all the VAX group people whose supervision is a precious help in my research. And I'd be happy to discuss your question during the discussion section. Also, feel free to reach out by emails if you have like further thoughts or questions. Thank you.
Thank you, Jordan. And now for our last presentation, Vin Leray.
Thank you, Amy. And again, thanks to all on the organizing committee for selecting this symposium for presentation. So my focus is going to be on estimating toxicities of polypharmacy. And I'm specifically going to talk about evaluating rates of one particular type of toxicity, severe acute liver injury, after initiating of drugs with reports of hepatotoxicity. My disclosures are on this slide. I have no consulting to report. And Jordan had showed this conceptual framework that Amy had originally shown. And each of us has tried to take different aspects of this overall conceptual framework. I'm going to specifically focus on toxicities for the purpose of this presentation. So really, there are very few studies to date that have examined toxicities of polypharmacy, and I certainly think that these would necessitate consideration of the medications of interest, potentially even evaluating the mechanisms by which a harm of interest might take place. And different approaches could be used here to evaluate rates of different health outcomes. I'm going to provide one approach focusing on severe acute liver injury as an endpoint. I certainly think that real world evidence on rates of any particular toxicity, but in this case, severe acute liver injury, after initiation of medications of interest is lacking. But real world data could be used to address a number of important questions on this topic. For example, what are rates of severe acute liver injury after initiation of prescription drugs, particularly drugs with known reports of hepatotoxicity? And I think a recent paper from the journal Hepatology attempted to categorize the hepatotoxic potential of drugs based on categorizing the likelihood of acute liver injury according to the number of published reports of acute liver injury. And this particular paper divided 220 drugs into the likelihood of developing acute liver injury based on the number of reports. So category A, 50 or more cases of drug-induced liver injury, 48 drugs. Category B, 12 to 49 cases, 76 drugs. Category C, 4 to 11 cases, 96 drugs, for a total of 220 drugs. But I think questions from this remain, including, do rates of severe acute liver injury correlate with the categories based on these number of reports? And what are the drugs that have the highest rates of severe acute liver injury? So to begin to address these questions, and particularly more overarching the toxicities of polypharmacy, we sought to determine the rates of severe acute liver injury after initiation of these category A, B, and C drugs. Again, these are drugs with known reports of hepatotoxicity. And we hypothesized that the categorization of these hepatotoxic drugs based on published reports would not accurately assess or reflect the rate of severe acute liver injury. And that hypothesis number 2, we would identify groups of drugs with high rates of severe acute liver injury. So we conducted a series of retrospective cohort studies of new initiators of category A, B, and C hepatotoxic drugs, again, using data from the Veterans Health Administration that Amy had referred to, in this case between 2000 and 2017. We included patients who had an outpatient prescription for any of the category A, B, or C drugs from the period of interest 2000-2017 and had at least 365 days in the VA prior to initiation of the drug with no prior prescriptions. And we excluded patients if within that 365-day period prior to initiation of the drug, they had evidence of severe acute liver injury, which was our main outcome, since we were interested in looking at incident events, and these would be prevalent events. If they used warfarin or a direct oral anticoagulant, since anticoagulation due to severe acute liver injury was one of our which was a key component of our endpoint. If they had chronic liver disease diagnosis, we didn't wish to ascertain likelihood of acute liver injury arising from prevalent liver disease. And so for these analyses, to avoid misclassification of severe acute liver injury events due to prevalent chronic liver disease, we excluded individuals with pre-existing chronic liver disease diagnoses. And further, given that some patients may have undiagnosed liver disease, we excluded individuals with an alanine aminotransferase greater than 100, an alkaline phosphatase greater than 172. These represent approximately 1.5 times the upper limit of normal of these assays in the VA system, or if they had at least 2 ALTs above 60, the approximate upper limit of normal of the assay, within 8 weeks of time. We ascertained new initiators of the category A, B, and C drugs, again, by at least 1 outpatient prescription with no use within 365 days prior to the index prescription. We defined the index date as the date that the drug was initially dispensed in the outpatient setting. We didn't evaluate 25 of the 220 drugs that were either not marketed in the US or not dispensed in the VA system during the study period, that were administered mainly in the hospital setting, that were anticoagulants, or which were used mainly for treatment of chronic liver disease, or which were topical, otic, ophthalmic, subdermal, rectal, or vaginal formulations. So focusing not on those formulations. Our main study outcome was severe acute liver injury, which we defined as an outpatient or hospital international normalized ratio greater than or equal to 1.5 off anticoagulation therapy, plus a total bilirubin greater than 2 times the upper limit of normal. Both of these had to be present within 30 days of each other. This definition really indicates severe hepatic dysfunction, where there's been a serious injury to the hepatic cell liver mass, liver mass fraction that is serious enough to impair hepatic function. And it's been used by the FDA's Sentinel system to assess serious drug-induced hepatotoxicity in the post-marketing setting. This schematic shows our patient follow-up. We define the index date as the date that the drug was initially dispensed in the outpatient setting. That represented the start of follow-up. The 365-day period prior to that represented the baseline period during which we ascertained things like chronic liver disease, anticoagulant therapy, or undiagnosed liver disease. And patients were followed until either the primary outcome, which was severe acute liver injury, or one of several censoring events: death, drug discontinuation, which we defined as no fills 30 or more days after the drug's last day's supply, incident prescription of warfarin or a direct oral anticoagulant, since that would obviously compromise our ability to ascertain coagulopathy due to liver disease. 12 months after the index date, particularly for chronic drugs, since really after this date, it was less likely that severe acute liver injury might be due to a drug, or the end of the study data, September 30th, 2017. We then calculated incidence rates of severe acute liver injury. So we determined person time of drug exposure for the 195 cohorts of interest, calculated the age and sex adjusted rates of severe acute liver injury with 95% confidence intervals for each of the 195 drug cohorts. And we included a drug cohort in our primary analysis if it met at least one of the following: if either the width of the 95% confidence interval for the severe acute liver injury incidence rate was less than 3 times the point estimate, or there was at least 2,000 person years of follow-up. And the rationale for this was to ensure that we would have sufficient power to detect severe acute liver injury events and to provide meaningful estimates of those rates. We then arranged the drugs from the highest to the lowest incidence rates of severe acute liver injury and grouped the drugs, organized the drugs into groups. Those groupings were based on substantive gaps in the rates and seeking manageable group sizes. So group 1, the highest incidence rate were those that had at least 10 events per 1,000 person years. Group 2, 5 to 9.9 events per 1,000 person years. Group 3, 2 to 4.9 events per 1,000 person years. And we considered these 3 groups to be the most hepatotoxic drugs, the most hepatotoxic groups. Group 4, 1 to 1.9, and then group 5 was less than 5 events per 1,000 person years. So here are our results. Just to give you some sense of the sheer depth and breadth of the drugs that we looked at. This is the 195 drugs categorized according to the initial category A, B, and C from the hepatology paper that grouped the drugs according to number of case reports. So these are the key findings from our analyses. This forest plot shows on the x-axis the age and sex-adjusted incidence rates of severe acute liver injury with 95% confidence interval in units of events per 1,000 person years. The point estimate with the 95% confidence interval is provided for each of the drugs listed at left on the y-axis, and the precise number and 95% confidence interval is indicated at right. Again, you'll see from the snapshot of the table I show at the bottom left, group 1 represents those drugs that had incidence rates of 10 events per 1,000 person years or higher. Group 2, those with 5 to 9.9 events per 1,000 person years. In group 3, those with 2 to 4.9 events. Additionally, the color coding of the point estimate and 95% confidence interval, orange represented the original category A drugs, those that had 50 or more cases of drug-induced liver injury. The darker blue, category B, 12 to 49 cases, and then the light blue category, or original category C, those with 4 to 11 cases. I think you'll see here from this figure that there was quite considerable variability in the incidence rates of severe acute liver injury. But you'll notice that despite the high number of case reports for category A drugs, only 1 of the group 1s were category A, only 3 of the group 2s were category A, and only 8 of the group 3 were category A. So overall, for the 39 drugs that are listed here in groups 1, 2, and 3, only 12, or about 31%, were actually category A drugs. In addition, one of the other findings, if you peruse the medications that are listed at left, 18 of the 39 drugs, or 46%, were actually antimicrobial drugs. So antimicrobial drugs represented the most common medications of the group 1, 2, and 3 drugs. Similarly, this is the figure for the age and sex-adjusted incidence rates of severe acute liver injury for the group 4 drugs. Again, those with at least 1 to 1.99 events per 1,000 person years of severe acute liver injury. Again, considerable variability between 1 and 1.9. Again, and not many necessarily from the category A. Whereas for group 5, these are the drugs that had incidence rates of severe acute liver injury less than 1 event per 1,000 person years. Many more category A and B drugs in this list. Potential limitations of our analysis. So we took this from we took obviously a pharmacoepidemiologic approach, and there is the potential that we may have misclassified severe acute liver injury because we didn't determine that the cause of acute liver injury. Obviously, for the clinical challenges that are inherent in classifying a drug-induced etiology of acute liver injury, and it's possible that some of these events may have been non-drug induced, or potentially due to the condition that the drug is treating. There's a potential for misclassification of drug exposure due to non-adherence, and this analysis was generalizable to a VA population with no chronic liver disease, though we excluded patients with chronic liver disease to increase the likelihood that the severe acute liver injury events were more likely to be drug-related. What did we conclude from our analysis? Well, the rates of severe acute liver injury varied widely among the initiator of the drugs that had at least 4 published reports of hepatotoxicity. And I think I showed you that it was quite clear that the number of reports didn't necessarily reflect the rate of severe acute liver injury for a particular drug. We were able to identify drugs with the highest rates of severe acute liver injury. And I think this approach could be used to estimate rates of toxicities of known pairwise drug interactions that Kersha and Jonathan had talked about, or other polypharmacy measures that either Christopher or Jordan had referenced. And potentially this approach could be used to develop and examine a toxicity index for a host of outcomes across different polypharmacy definitions, drugs, and drug classes. I want to acknowledge my colleagues at University of Pennsylvania, Stanford, Yale, the Veterans Health Administration, and our funding source, National Cancer Institute from the US NIH. And I thank you all for your attention.
Thank you, Vin. So if we can just go to the bottom here. Sorry.
From current slide, I think, or that, yep, either one, yep.
So just to quickly try to summarize some of these presentations in preparation for our discussion. We've discussed evaluating multiple definitions of polypharmacy, whether that be medication count, potentially inappropriate medications, drug-drug interactions, etc., and the issues around confounding by indication. We've also talked about considering the relevant interactions, such as drug-gene interactions, drug-alcohol and substance use interactions, drug and comorbidity interactions, and machine learning approaches to doing this. And we've examined toxicities from Vin Mulleray's presentation. So the questions for the discussion, to at least help start the discussion, is what other databases might be well suited to this work? The VA database is rich and very helpful, but we certainly want to consider other databases. Also, how can we separate correlation with medication count from causation? That's obviously a question for all of us ongoing. And what might best inform future intervention studies? So with that, I would like to turn the discussion over, and I'm going to stop sharing my screen here.
Thank you, Amy. Yeah, we have received a number of excellent questions in the chat thus far. I will start going through those, but I will also continue to monitor the chat for any additional questions. Or if you want to raise your hand as well and speak live, that would be brilliant as well. And we can try to emulate a live symposium as closely as possible in this virtual world. So first off, how about we go in reverse order since it is fresh in our heads. Vin, where are you going next with your research now that you have developed a pipeline to study liver toxicities? Any translational efforts of your findings on liver toxicities? Are there are there plans to study other toxicities?
Yeah, all good questions, Chris. And I thank whoever it was that that asked that question. I think, probably the next step for us is to actually, I alluded to this on the last bullet of my next to last slide, was to develop a hepatotoxicity adjustment index. I mean, our group at Penn has done a number of analyses that have looked at rates of severe acute liver injury associated with drugs within particular classes. These all antifungals, antiretrovirals, just to give you some example, direct acting antiviral drugs. But one of the constant criticisms of our work has been we don't necessarily take into account multiple other potential hepatotoxic drugs in these analyses. And I think if we can come up with some adjustment index that looks at which of the particular drugs may be accounting for the incidence rate within some baseline period or potentially during follow-up, from a pharmacoepidemiologic standpoint, that would allow us to account for many other of the most hepatotoxic drugs. I think additionally, most sort of immediately, I think accounting for concomitant hepatotoxic drugs and potentially doing sensitivity analyses to exclude those concomitant hepatotoxic drugs, and to see if the groupings that we had were preserved is going to be the next analysis. We've done initial aspects of this already, and it at least would suggest that those groupings are indeed preserved, but certainly having those results and available will be another step. And then I think, you mentioned about, translational, future translational research. I think, from the standpoint of polypharmacy, trying to sort of account for numbers of drugs, potentially, drug gene, alcohol effects, looking at these analyses in the setting of chronic liver disease, maybe viral versus non-viral liver diseases, alcohol liver disease would be also a viable next step, again, under the umbrella of liver injury outcomes. But then certainly to look at other drug outcomes. Cardiovascular disease, I think, would probably be a next realistic step, and potentially acute kidney injury, just given the fact that certainly nephrotoxicity, cardiotoxicity, hepatotoxicity are three of the most common reasons for medication-related toxicity withdrawal from the market, preclinical for drugs.
Thanks, Vin. Now to Jordan about the measurement of polypharmacy. When we are talking about medication count, how did you handle the fixed dose medication regarding the medication interactions? And also, what about different dosage forms? Any comments from you on how our measures of polypharmacy thus far have incorporated dose?
Yeah, thank you. That's a great question, and it really depends on the database. In the VA, we have the number of units, we have the dose, we have the duration of treatment, so we can estimate the dose the patient is actually taking. In the French database, it's more complicated because since we have no duration of treatment, we have only the number of units and the dose. We cannot really be sure of the dose the patient is actually taking. But we have other resources. We have the ATC code. So with the ATC code, we have the therapeutic class. So we can assume what dose the patient is supposed to take. There are still some limits. For instance, aspirin at a high dose, it can be used as an anti-inflammatory drug, and it shouldn't be used chronically, or it should be used with a PPI. And if you use aspirin at low dose, it can be an anti-aggregant drug, so it must be used chronically. So it might be tricky to define if your aspirin is actually a PIM or not a PIM. So we can set up algorithm to look at that, considering all the resources we have. So we did that for aspirins, but with polypharmacy, the problem is you have like so many different drugs sometimes you cannot really identify all these very particular treatments.
Thanks, Jordan. And in real time, we have a quick follow-on for that that's quite related, so I'll put it to you now. Ajda in the chat says, but doesn't aspirin have different indication and therefore a different ATC code?
Yes, exactly. But sometimes in France, people use aspirin for kids as an anti-aggregant drug. So in this case, the aspirin will have the ATC code of an anti-inflammatory drug, but it is still used in adults as an anti-aggregant. So you have to identify that. You have to identify if you see an adult taking an aspirin for kids at a low dose chronically, it's probably an anti-aggregant drug, even if you have the wrong ATC code.
Thanks, Jordan. A set of questions for the duo, Kirsha and Jonathan. We'll start with ones that are focused more towards Kirsha, and then we'll add in a few other ones. So for Kirsha, who were the patients most likely to have polypharmacy? For example, based on age categories, race, ethnicity, sex. And I might just jump in and add, following from the plenary that we had this morning, on equality, diversity, and inclusion in pharmacoepidemiology. Did you assess, or do you have any plans to assess for any health disparities in your population related to polypharmacy?
I think older age were more likely to have polypharmacy, and whites were more likely to have polypharmacy. In terms of assessing diversity in polypharmacy, that is something, yes, we're interested in looking at. But that's for future work with updated medication profile. So when we update patient medication profile in more recent years, hopefully follow up 2018, we'll take a look at that.
Indeed.
Anything to add, Amy, or that was?
Good answer.
Yeah, indeed. And one of the key benefits that we have with using data from the Veterans Administration in the US is that we do have quite excellent capture of racial ethnicity groups over time and in repeat succession too, every time they touch the health system. So we can see, yes, patterns in how people respond to that question.
And I would just add too, and Amy could certainly jump into this, but I know that there are groups in the Veterans Aging Cohort Study that have sought to even improve our capture of Hispanic ethnicity with an algorithm that will utilize things like name, for example, beyond just the categorization of race and ethnicity. So, I think that kind of methodologic work, utilizing the data to come up with advanced algorithms to classify patients, based on, in this case, ethnic background, may actually be really, really valuable to determine if toxicities arising from polypharmacy may differ based on, certain racial or ethnic backgrounds. I don't know, Amy, if you wanted to comment.
Well, so consistent with that, of course, is hepatocellular cancer. We know the risks for hepatocellular cancer are greater for people of Latinx background. And actually the study that Vin is talking about, which we haven't published yet, but we found that actually by using these indicators for other ways of capturing who might be Hispanic, especially older individuals who might be Hispanic and a bit less likely to endorse their ethnicity, that we actually increased the association with HCC for people of that background. So I think it is a very important question, especially if we're looking at liver injury questions.
Absolutely. Jonathan, one for you. Can ML machine learning be used to identify novel or even unknown drug-drug interactions?
Yes, and that's really our plan moving forward, is to use machine learning techniques to try and discover these. I would describe some of the machine learning techniques we want to use, like IRF, to traditional statistical techniques, in that if you have the statistical signal, it will find the relationship However, it's also very good at finding other known causes. So one of the main reasons we wanted to look into known pairwise drug interactions is because if using a machine learning technique with completely data agnostic, it will tell you the known pairwise drug interactions very quickly and say that these have large effects. However, once you know those effects, you can start accounting for them in the model, therefore allowing the model to pick up evidence of unknown potential drug interactions.
And Jonathan, IRF is?
Iterative random forest, sorry.
Mhm.
It's an algorithm I'm very familiar with, and I forget that not everyone is.
No, not even us who have worked with you for years. This one's from Juan. I think Kirsha, you might be able to answer this, or Jonathan, but I do think it's related to what you presented on the KDPI. So how was the index date operationalized with the concept of KPDI? Was it second drug fill?
So for my analysis, the way it worked is we had the year of data collection, and overlap was considered if patients had overlapping prescription time. So for any given prescription and fill, there was a period of time associated with that. And if two drugs had overlapping time periods, those were considered they were used for drug-drug interaction.
I think the question focused on what was the baseline window, Kirsha?
Yeah, the baseline window was from 2008 to 2009. It was a year.
And why did we do that?
We did 1 year to identify people's profile, and their pharmacy profile and their characteristics.
So we could look at long-term.
So we can look at it long-term for mortality and hospitalization.
Juan, I know you're not shy. Feel free to come off mute if you have any follow-ups.
Thank you, Christopher. Yeah, no, fascinating presentations. Thank you, everybody. My question on the KPDI, and sorry if it is KDPI, I'm confused with my acronyms right here. It's when does the follow-up start for these patients? So I understand there has to be some overlap for them to consider concomitant use. So that raised another question. How long is that follow-up minimum? And the reason I ask is because I have done some research on this where we looked at 30 days versus 45 days overlap versus 90 days to see when actually it is overlapping concomitant use versus switching. So my question is, how long is that overlap that you look at? And then for the follow-up, when is that? Is like the second drug because it's paired. So is that the second drug dispensing? And that's at the point that you start following up?
We started following people from the end of baseline, which was 2009, and we followed them from 2009 to 2015. So in terms of their drug profile, we ascertained their drug profile in 2008 to 2009, and any overlapping period within that year is captured.
Okay, and do you think that might have introduced some misclassification because of switching instead of like concomitant use that was happening over time?
Because of how we allow for refill gapping, we were able to determine that it's a true overlap, not a switch, if I recall that correctly.
Right. If you, Juan, if you recall the presentation that Jordan and Chris made about how we determined periods of active medication.
Correct. Yeah.
That technique was used.
Okay.
In that year-long observation window.
Okay. Got it. Thank you.
Thanks. Excellent discussion. I've got one, I think, for me from Petra that I'll read out loud. The question could also be whether there might be better or other measures than the Charlson Comorbidity Index to use. The Charlson Index may focus too much on mortality instead of the type of morbidity outcomes you'd be interested in. So thinking of the confounding diagram, what we are trying to identify is a measure or set of measures that appropriately account for confounding by indication when studying polypharmacy. So one approach, as we suggested, is using these general measures of health status. And so far, we have used the Charlson Comorbidity Index for multimorbidity and VAX index as a measure of physiologic frailty. Of course, there are many, many other indices in use, capturing multimorbidity, for example, the Elixhauser, which I think has 30 different comorbidities. You've got the electronic frailty index, which includes 36-ish comorbidities, but also disabilities, symptoms, and other factors, including polypharmacy, is in the electronic frailty index. So something to think about when trying to study the effects of polypharmacy. But I mean, more generally, Petra, we could indeed try to identify indices that are less focused on mortality and more on the specific morbidity that we are assessing as an outcome. But to be honest, we have a wide range of outcomes we would like to study, and finding an index specific to each of these outcomes may not be feasible. So for this, we are currently exploring other approaches like propensity scores, or even more likely, given polypharmacy and multimorbidity at play, high dimensional propensity scores, and see whether they could help us.
And another example, Chris, that I know you've played around with is looking at anticholinergic indices and controlling for that as well, especially for neurocognitive outcomes. So we certainly are in the business of trying to find other ways of accounting for these factors and looking at the weights.
Indeed. Thank you, Petra. And on top of that, Amy, if you want to stay off mute, Jeffrey asks, is anyone looking at polypharmacy induced or aggregated anticholinergic cognitive burden or sedative burden or drug-induced long QT syndrome burden or competitive inhibition, the CYP450 drug interactions?
Well, as I mentioned, Chris has looked at anticholinergic cognitive burden in terms of looking at pneumonia risk, and we're also looking at that in relation to cognitive diagnoses, delirium dementia. We have not looked at long QT yet, but that is a very big interest, I think, that we have, because the VA does have EKG data where we could actually look at actual QT, length of QTs. In terms of competitive inhibition for C450, we have not gotten into that, but we would be interested in talking to people who are interested in doing that. We are conducting a study right now where we're going to also have substantial genetic data. And that is certainly something that we want to look at more generally, both known drug pharmacogenomic interactions, and then looking again using AI techniques to find unknown but important ones.
And I was going to put to you what are the group's next steps, but that seemingly answers it right there. And we are at the end of our time today. So just wanted to be respectful of everybody's times. Thank you, everyone, for attending the symposium on polypharmacy, which I believe is the first symposium that ICPI has put on for polypharmacy, and we hope not the last. So please do reach out to us if you have any follow-up conversations that you'd like to have. There were 2 or 3 questions that unfortunately we didn't get to. Please do not hesitate to reach out to one of us for any follow-ups. Thanks again.